Yeah. Can you hear me? Hello?
Yeah, your audio is clear, sir.
You're audible,
sir.
Yeah. Okay. Yeah, the screen is visible, correct? Yeah, thank you.
Yeah.
Thanks, Mulay, for that introduction, and I thank the organizers for giving me this opportunity. Since we are running late, we'll start with the topic straight away. I've been asked to talk on minor pediatric office emergencies. Of course, sitting in a tertiary care center, I may not be the correct person to talk on this, but we do see a few of these minor emergencies in and around Pondicherry who come to us. So with that experience, I will try to do justice to the topic. In the next 20 minutes, what we're going to do is just case-by discussion on 4 of 5 case scenarios, which is we'll try to see how they can be managed in the office pediatrics. So the first case is an 18-month-old girl who was brought with complaints of choking on a plastic toy which she was playing around 30 minutes back. On arrival, she is coughing repeatedly and is irritable and has respiratory distress. Parents are worried and wants you to do something immediately in your clinic. So what would be our response? So there are multiple things we can do. We can arrange to refer the child immediately to the nearby hospital. If you have an X-ray facility somewhere nearby, you can send her for an X-ray and see if really she has ingested anything. And then we can try some first aid measures. We have been taught Heimlich's maneuver or back slaps and chest thrusts, during our training. We can of course reassure and calm the parents as she might have coughed it out and nothing to worry. So from all these options, for most of the time when I ask my residents or other people, they always go for this C, because all of them feel that child is come with an acute event and we should do something, and we should do some first aid, which is so let us see what we should do. Why this choose trying option C sometimes can be dangerous. So what is most dangerous in a child who is coming to you with a foreign body aspiration is a complete airway obstruction. So that happens only if there is a laryngeal obstruction. The larynx and subglottic area is the narrowest part of your airway. So foreign body can get lodged there, and if there's a complete obstruction, they can die immediately. So that is the most life-threatening thing which you're worried about. So how does a laryngeal foreign body present? See, first, most of the features will be that they'll have no cough, no voice, because larynx is obstructed completely. So they won't be able to make any noise. They will not be coughing. And the universal choking sign, even though they're described in adults and sometimes it can happen that the foreign body is actually passed in the larynx and in the lodged in one of the smaller airways, either the right bronchus or the left bronchus. And when you do some first aid measures like Heimlich's or chest thrust, this foreign body can get dislodged and go back up into the larynx. And especially vegetable foreign bodies, they swell up after they enter the airways because they absorb water, and when they go back, even though they were small enough to pass through the airway larynx before, now they may big enough and they may get stuck completely and produce complete obstruction. So it can be counterproductive. And most of these first aid measures, what we do, Heimlich's maneuver or chest thrust, they are just imitating a cough. The mechanism of how they act is they increase the intrathoracic pressure and push the foreign body out. So that's what we do when we cough. So they're just an imitation cough. So when the child is actually coughing, you should not try any more imitations and just wait for the child to handle it. In this child, it is dangerous. Even if the child has stridor, that means some sound is being produced. That means airway is not completely obstructed. These first aid measures are used only when the airway is completely obstructed. So in this child, we just need to watch for what's going to happen. Okay, so is the bronchial foreign body that is not an emergency? Of course, it's an emergency, but it's not a dire emergency where we need to do something immediately. The foreign body in one of the bronchus, even if it is one of the main bronchus, the other side, the lung is completely able to work, and it will save the child, and we can wait for even 24 hours or 48 hours. So it's not an absolute emergency. We can safely refer the child to a hospital where they can do bronchoscopy in a controlled situation. So when to refer a child? If you're in the clinic, a child like this comes, when to refer the child? So you first of all examine the child in great detail. So is there any evidence of a decreased air entry, either unilateral or bilateral? Carefully look for it. Any respiratory distress or any noisy breathing. And if you have a facility, take an X-ray. Any abnormal chest X-ray. Look at the two lungs field and if they look symmetric or not. It can be a collapse, hyperinflation, mild asymmetry. Those things indicate that there is some airway obstruction, either complete or partial. If all these things are normal, then most probably, even though there's a choking episode, most probably there's nothing serious. And you can even observe the child. Our common practice is if the child is high distress and bilateral air entry is symmetrical and good and X-ray is normal, and then we usually observe the child. We don't do check bronchoscopies in our hospital. So we can actually observe the child without refer unless the parents are very worried. So this is another similar case which was shown to us by Professor Tangavelu sir many years back. I'm just borrowing from sir this case. So this is a 2-year-old Down syndrome child with body complaints of drooling of saliva since one day. So suspecting that child might have swallowed something, they took an X-ray, and there was a round metallic object looking like a coin. So it was removed very easily with the help of a surgeon. But still, even after that, child continued to worsen. The child developed an air leak, as you can see here. There is some amount of subcutaneous emphysema. When they looked at the metallic thing clearly, they found that actually it was not a coin. Actually, it was a button battery. This button battery is a very dangerous thing. First of all, you should be. It's got two edges, with a shallow ridge in between. So that can be sometimes seen in the X-ray. Sometimes the lateral view also we can see a slight slanting slope from the one side to the other side. Okay. So these are signs. If you see like this and look carefully, you may be able to pick up a button batteries. Very, very important because button batteries can be very, very dangerous. You know why? It's dangerous primarily because it produces extensive tissue damage, not because of chemical leak. That's what I used to think many years back. But the way they produce damage is through electrical circuit. So this is a diagram which is on the internet about how to handle button batteries by one of the companies which make button batteries. They say you should not touch the battery like this. You should only hold it like along the edges. That is because this battery, one side is positive charge, other side is negative charge. And if you hold like this, the circuit can be completed through your hand and it can slowly get discharged. So this happens when you just button battery. Child injects a button battery and is lying in some tight cavity like nose, ear, pharynx, or esophagus. The mucosa, along with the secretions, the mucus act like a very good conducting gel. And the circuit is completed, battery is short circuited, and even if the battery is old, it will have enough current to burn the mucosa. So it basically cauterizes the mucosa and the surrounding tissues. In fact, I had seen actually 2 children who had massive hematemesis following button battery injection, where even the aorta was eroded, and we lost them. So if the child comes to you with a button battery injection, it's an immediate, it's a very acute emergency. Child has to be referred to a place where it can be taken out as early as possible. In rare circumstances, if you find the batteries reach the stomach, then this danger of perforation and damage is very less because this short circuiting is unlikely to happen. So, and if the battery is less than 15 millimeter, usually it passes out safely. But button battery is always a very dangerous thing. Now go to the next case. This is a 2-year-old developmentally normal girl who was born complaints of first episode of abnormal movements 1 hour back. Child appears to be normal and interacting when seen with you. So you don't know whether the child had a seizure or not. So how do you distinguish? Because seizure means there are a lot of different ions comes in and you may have to treat them differently, especially multiple episodes are there. So there are some green flag signs for seizure mimics and some red flag signs for seizures. This is taken from one of the review articles. So the movement is suppressible by tactile stimulation. Suppose any movement which you can stop by your own touching the patient easily, then that is a seizure mimic. And seizure mimics are usually triggered by specific event, location, or emotion. For example, a breath holding spell where a painful stimulus, or child gets upset, or standing for a long time in an assembly line. So this is, usually there will be a triggering event. And the movements or the staring or vacant stare or whatever you describe, the mimic usually stops. You can with the distraction. That means child actually has not lost consciousness. You can distract the child. But if it's a seizure, then most of these movements are non-repressible, and seizure, the triggering event usually, suppose mother says that usually when they get up from sleep or around that time, when coming out of sleep only it happens, then that is highly suggestive of seizures. That is a very threshold, low threshold for seizures. The sleep, around the sleep and waking from sleep is a time when seizures can be exaggerated. And loss of consciousness during an event, any history of loss of consciousness, any post-event, if there is some drowsiness or fatigue lasting for half an hour to 1 hour, highly suggestive of seizure. Then, of course, any past history of developmental delay, regression, or neurological injury. So, taken alone, none of these red flags or green flags are actually reliable. But if taken as a whole, suppose a child has a lot of green flags and hardly any red flag, or a lot of red flags and hardly any green flag, then we can say differentiate a seizure or a seizure mimic. Of course, there is a lot of big list of seizure and seizure mimic. We are not going to go through all of that. Common confusions, just as an example, I've taken breath holding spell for infants. If you carefully take a history of breath holding spell, the cyanotic episode, the holding during aspiration, and the typical age group, you will find that The mother description involves a lot of green flags and hardly any red flag. Less than 10-15% of them can have any transient loss of consciousness or convulsions. If that is there, of course, there can be a confusion. In that case, we may have to do further investigations, which we will discuss later. For example, syncope in an older child. This is similar. It's a common thing which get confused with seizure. Even yesterday, one of my pediatric ICU sisters brought her daughter, who is around 9-10 years, who had a syncope and was standing in church. But somebody had, outside had advised MRI for her, and she was coming and asking me what to do. So sometimes in syncope, you can have some oral-like symptoms which may confuse you for a temporal lobe epilepsy. They can have occasional jerking of limbs, some urinary incontinence, can rarely be there. But if you ask history very carefully, you find that these movements in syncope, if at all any movements are there, usually they are not there. They are actually high amplitude twitching lasting only a few seconds, like a jerk. Unlike seizure, which are rhythmic, and last for longer time and multiple movements. And the fall, when the fall from a syncope is more gradual as compared to an atonic seizure, usually they don't hardly ever injure themselves seriously when there's a syncope. And usually there will be no fecal incontinence or any tongue bite. And usual trigger factors are quite typical: long standing like an assembly line or a church, exercise, heat, etc. Okay, so the most important thing is again evaluating the child for taking detailed history for the red and the green flags. And if there is a doubt, the next thing to do is not a imaging. Better to do an EEG. If video EEG if available is very useful, because suppose child has a particular seizure mimic during the EEG, then we can actually look at the EEG signatures. Yeah, and of course this has been already discussed. If it's a seizure, what to do. I'll skip that. Now come to case 4. So case 4 is a 5-month-old boy who came with excessive crying for one day. He did not have fever, was feeding well, was occasionally consolable, but he was uncooperative for examination, as most of the children are, and was observed after giving some Finagar or some sedative. But that lasted only for 1 hour. He was quite only for 1 hour, and again he started crying. So mother was unwilling to go home. We need to figure it out. So this is a common scenario: a child with incessant crying. So the issues which faces is, can a normal, well-appearing infant presenting with acute excessive crying as a sole symptom can have a serious underlying disease? And if so, then what test or lab investigation or test can help us find this thing? So the important thing here is there is no, even though there is a big list of things. See, I've taken it from some book. There is 3 slides full of causes for incessant crying. So there's no way we can rule all this out. So this laundry list evaluation will not help. So maybe a better thing to do is do a systematic approach. Where step 1, you wrote any life-threatening conditions. And then once you reasonably ruled out life-threatening conditions which can present like this, then you can go for common benign conditions. Even after that, you're confused, then it may be better to observe the child till either the symptoms completely disappear or something else comes up and you're able to diagnose. This is what we usually follow. I usually follow. So step 1 is serious things. So what are serious things? We already had a discussion on how to pick up evidence of compensated shock. Look for subtle signs like change in mental status, prolonged CFT, or difference in central and peripheral pulse. Look at subtle signs for compensated shock. If that is there, of course, then you're dealing with a serious situation. If that is not, then look at temperature instabilities. Especially fever is there, then look for infections which are not very obvious. Like for example, a common example is a urinary tract infection. So look for that, septic workup. Some of the children, then make sure you check an SpO2, because some of the children, especially with the neuromuscular disease, they may not have obvious distress. So respiratory tachypnea or retractions. So if SpO2 is low, hypoxia without much distress, then suspect a neuromuscular disease. But when you check SpO2, suppose suddenly you find that actually SpO2 is low, and then you look carefully, child has some distress actually. Then actually you may be dealing with a cardiac or a pulmonary disease. So SpO2 is useful for screening. And look at the heart rate. The heart rate is persistently very high, more than 200, 220, and not coming down at all, even with some calming medications what you have tried. Then think of an arrhythmia. And of course, any bilious vomiting or abdomen distension, think of a surgical thing. Malnutrition, interoception, which Dr. Kumar will be dealing with in the next talk. And look at the fontanelle always. Bulging fontanelle with seizure, irritability, and vomiting, of course, suspect infection, serious infection or trauma, IC bleed. Any rash, history of rash anywhere recently, or even the mother for an infant, think of herpes encephalitis. Then pupillary signs, look at the pupils, any tremor, pupillary signs, any hypertension, tachycardia, and any J symptom. These are signs of some toxin ingestions. Either it is, or a scorpion sting. Once we had a child who had scorpion sting, who mother did not notice scorpion, so child was having irritable cry. There are all signs of autonomic disturbance when you look carefully at it. So toxins and metabolic causes stings can be thought of. If all these things are ruled out, then most probably you're dealing with something benign. So common benign conditions are these, even nasal congestion, URI, throat, stomatitis, pharyngitis, insect bites, foreign bodies in the ear, nose, pharynx, caudal abrasions, anal fissure, post-immunization, of course, some drugs, and especially sympathomyometic drugs given for common cold, digital tourniquet. So these are the common things. So just have a head to toe, carefully, completely strip the child and examine, complete a thorough examination, you'll be able to find it. So basically, thorough physical examination is the key. And if again after that nothing is found, just observe the child, especially since you ruled out most of the dangerous conditions. So case 5 is a 2-year-old child brought with the allergic history of floor cleaner 1 hour back at home. On examination, child appears conscious, interactive with stable vitals. This is a common thing. Our household has maybe a dangerous place for small toddlers and infants. So many chemicals are there. They can ingest so many things, starting from floor cleaner to toilet cleaner. Nowadays, a lot of hand sanitizers are there. Srinivasan already mentioned about mosquito repellents and all that. So this is a very common thing. And they present to you. They look all right to you. So what to do? So first question is, should we do a stomach wash? If you look at the evidence, the literature, there are strong recommendations. For example, this is a position paper from clinical toxicology from both American and the European toxicology groups. Okay, so they definitely say that it should not be performed routinely. And if at all, for the treatment of poison patients, in the rare circumstances in which it's used, it should be performed by individuals with the proper training and expertise. So in a peripheral clinic, in an office practice, it's better to avoid this because sometimes they can have dangerous consequences and the benefits have never been proven. And most of the household chemicals, they may not get benefited by an algacic lavage, and suppose there are some corrosives, they can produce more damage. So it's better to avoid stomach wash. Unless, of course, you want to do it as a punishment for the child. Also, you want to repeat the act, but that's not our intention, of course. So we are not going to do it. Stomach wash is dangerous in the peripheries. What about activated charcoal? Even same group has also mentioned that its role is also doubtful. Yeah, so it's got a different role in some medications and other things, what Srinivasan has already pointed out. But a child coming to you with a household ingestion, this kind of chemicals, usually the role of activated charcoal is limited and better to avoid it. Okay. So single dose activated charcoal should not be administered routinely in the management of poison patients. That is a statement from the toxicology group, both European and American, with great evidence. So better to avoid that. Then whom to refer then? Suppose the child like this comes to you, whom to refer? Look up for evidence of corrosive ingestion because some of these toilet cleaning agents are strong acids. So one evidence for that may be to look at the child's oral mucosa. No child can ingest a corrosive substance without damaging his oropharynx. And so carefully look at the pharynx and oral mucosa. If everything is looking clean and nice, unlike the child has taken anything corrosive. But if there is a whitish tinge or erosions or congestion, then be careful. There may be more damage inside, so you should refer the child immediately. Of course, any systemic signs, seizures, autism, you should refer. Any significant GA symptoms, repeated vomiting especially, you should refer the child. And I made a partial list of dangerous household items. If parents say that this is the one they ingested, then you should be very careful, okay? Because these are the conditions, these are the things which we have encountered as children with severe morbidity and mortality in our institute who are ingested this. For example, kerosene or any hydrocarbon, petrol, diesel, any hydrocarbon, paint, turpentine, paint thinner, camphor, eucalyptus oil and neem oil, they can put this CNS toxicity. Already Srinivasan mentioned that they can come to status. Any household drugs which are like paracetamol poisoning already has mentioned. Suppose somebody in the household is taking some psychiatric medications, iron tablet, or hypoglycemic agents. If child has taken, better to refer because they can have complications.
Sorry, sir. 3 more minutes. Sorry.
Yeah. Sorry. We're coming to second last case. Almost last case. Yeah, 3-year-old child is brought history of alleged history of unknown bite on his right leg sustained while playing outside. Child is complaining of some pain at the locker site. Yeah. So except for the pain, nothing is there. Child has come to you. So what are the dangerous bites in our area? See, there are a lot of things which can bite you. A lot of insects are there, but actually what can kill you are only very few. What in our experience in our area, what we have seen is only snake, scorpion, and sometimes bee. Things like all this dangerous spiders, black widow spider, and all those things, dangerous stuff is not seen in this part of the country likely. So we need to identify when a child comes with an unknown bite, we need to just figure out whether it's one of these 3. Okay, so how do you identify a snake bite? It's very easy. Of course, if they've seen it, the snake, there's no problem. Otherwise, the first important sign for a snake bite is a significant local reaction, especially if the swelling is increasing rapidly. Suppose they say the initial swelling was only in the toes or fingers, now it's crossed one joint, then definitely it's snake bite. No infection, nothing else can spread so fast. Okay. The only exception is common crate. Common crate, where common crates sometimes can have absolutely, not sometimes, always, never has any local reaction. It can be absolutely crystal clear because there will be no sign at all locally. And of course, Fang box, if it is there, is useful. Clotting abnormality, all of us know this, how to do a whole blood clotting time. You just need any clean glass test tube or any vial. Take 2 to 3 ml of blood, keep it for 20 minutes. It doesn't clot, definitely something is wrong. Neurological manifestations. Okay, ptosis to start with, they can have any kind of respiratory paralysis, most common is ptosis. For this, obviously, this is another thing we should remember. The clinical manifestation of snake bite is a function of not only the amount of venom ingested, it's also how much time has elapsed since bite. So a child who's got a lethal dose coming to you with half an hour may look completely normal. But a child who's got a sublethal dose, not enough to kill him, but coming after, say, 8-10 hours may have significant local symptoms and all those things. So you should also take the time into consideration when you evaluate a child. Okay, what about scorpion? So scorpion sting, of course, the typical thing all of us can recognize is the characteristic autonomic storm, both sympathetic and parasympathetic overactivities, tachycardia, hypertension, profuse sweating, bronchoria, lacrimation, and priapism, etc. So, but the issue with this is commonly mistaken for shock. We had an excellent session on shock by Tangvalu sir. So the problem is a child like this comes desperately. There is no history of it's an unknown bite. Nobody knows something has bitten this child. Child comes to you with the signs. Child will be looking at tachycardic, cold extremities, profuse sweating, and the prolonged CFT. Commonly managed as a shock. We have seen many times. They be given IV fluids, started on catecholamines, and then referred. Okay, but this can be dangerous if it is scorpion sting. And why? Because first 4 to 6 hours of scorpion sting is a sign. It's time when there is a severe catecholamine over circulation. So the sympathetic storm is there. Catecholamine levels are very high. Child is severely vasoconstricted and tachycardia because of a lot of catecholamine circulating. Giving more catecholamines to that child is actually can precipitate cardiac arrhythmias and is dangerous. So please avoid doing this. So how to recognize this is this. If you carefully look at the child, the BP will be on the higher side of normal. Child will have hypertension. So that is immediately a suspicion. You should suspect that how can a child with shock and have hypertension? So that says that it's having a catecholamine storm. Then look for parasympathetic signs. If you're unusually in shock, especially if you're a boy, they can have priapism, profuse oral secretions, bronchoria. Those things are unusual in shock. So that should make you suspect that it may be a catecholamine storm, maybe a scorpion sting. Then the most important thing is that they won't have any signs of cardiac toxicity at the first 4 to 6 hours when the autonomic storm is happening. If you look at the heart, except for tachycardia, there will be no gallop. There will be no lung congestion except for some conducted sounds because of secretions, no crepitations, no respiratory, increased workout breathing. There is no hepatomegaly. So, absence of this should make you suspect that this could be it may not be cardiac failure or cardiogenic shock. But of course, if time is around 6 to 8 hours after scorpion sting, if the child has the same presentation, then usually they will have, you should think of cardiogenic shock and manage accordingly. That time they will have gallop, they will have respiratory distress, hepatomegaly, and BP will be also on the lower side of normal. Okay. All right. Yeah, bee sting. Bee sting is rarely, if it's not life-threatening unless there is large number of stings, but we have seen children getting very sick with even only 1 or 2 bee stings. Child has come with children with anaphylaxis or even acute lung injury in ARDS. So it should be taken seriously. Sometimes they can do badly. So when to refer this children with unknown bite? Snake bite, of course. If you know it's snake bite, you have reason to suspect. Even if the child looks completely normal, please refer because this children need to be observed for at least for 24 hours unless you have the facility to do that for your place. And if child has ptosis, any signs of neurotoxicity, please don't send out the child like that. We have an innumerable number of cases like this where children with the neurotoxicity have been referred and on the way they have arrested and they have died. But by the time they reach our hospital or any other tertiary care center, they would have been dead long back, cardiac arrest. Because sometimes the neurotoxicity can progress very fast. So if you're referring a child with already having an onset of neuroparalysis in the time of ptosis, unless it is few minutes, please somehow get secure the airway before referring. Try to get, intubate the child or accompany the child otherwise. Of course, the neostigmine and atropine is an option, the second option, but that works only for cobra bite. For crate bite, which is a presynaptic blockade, neostigmine may not work, and child can rapidly progress. So airway protection is very important by referring this child. Scorpion sting. If child has only local pain and no systemic features of an autonomic storm, child need not be referred. You can observe them. But if there's an autonomic storm, please refer. And when you're referring, please give the first dose of Corrosive, 30 micrograms per kilo. Thank you.
Thank you, Dr. Narayanan sir, for the elaborate presentation and the sharing your experience and knowledge with us. For want of time, we'll have a discussion in the chat box. I